Go ahead and get that door if you would. So as far as treatment goes for open injuries, we're already aware we have to control the bleeding, but that cannot take precedence over your own safety. Spurting blood, you may not know that's there, so be prepared to deal with the major bleeding. You may want to wear the booties, you may want to wear the gown, certainly want to wear the goggles. You don't want to be a hero and just come out drenched in blood and then find out they're HIV positive or Hep B positive or something like that. So please use universal precautions. And ding ding, absolutely high-level test questions. You will get a lot of these test questions. If it is a chest or a neck or any wound involving the airway, chest, neck, or any wound involving the airway. And your slide says upper abdomen because that's really close to the airway. It has to be covered with what's known as an occlusive dressing. An occlusive dressing simply means it's airtight. Gauze is not airtight. Saran wrap is airtight. Gauze is not airtight. Gauze impregnated with Vaseline is airtight. Aluminum foil is airtight. And we used to carry a roll of Reynolds wrap in the ambulance, and we quit doing that because it's got a sharp edge. So if I was trying to cover up an abdominal evisceration means the guts have came out. If I was trying to cover that with aluminum foil, which you should cover it with an occlusive dressing, but the foil had jagged edges and could cut the organs themselves. But foil makes a great dressing. It keeps you warm, radiates the heat back into you, it's airtight. Well, the foil would prevent that drying from occurring. A newborn baby that's having trouble monitoring or keeping its temp, foil would work great. We actually have little foil pouches. You survivalists with your get-home bag who want to go spend the night on the edge of the field trying to get home, you probably have the baked potato suit in your get-home bag. What do they call those?
Space blankets.
Oh, there's a name for them. Bimini? Benny? Come on, Luke.
We always just call them sleeping systems.
Sleeping systems? I'll think of that in a minute. So it's great. It keeps the heat in. And when you got abdominal evisceration, you're going to keep the heat. But the point of this one here is we got to make it airtight so we don't suck air in. What is another occlusive dressing readily available? In other words, I walk up and stare, you've got a sucking chest wound because old Butter stabbed you in the back. I just had to do it on purpose. He stabbed you in the back because you called him Butter. And they called me to fix it. I have a gloved hand. I seal the wound. So that's probably a test question. Upon arrival, you find a sucking chest wound. Your first action would be cover it with your gloved hand. Then your second action would be apply an occlusive dressing. Emily started that. You know, I had no idea until she started it. Then apply an occlusive dressing. In the textbooks, I'm not sure about this one, but in textbooks, they have demonstrated occlusive dressings. And when you buy Vaseline impregnated gauze, that's just a gauze pad that's smashed full of Vaseline. It comes in an aluminum package, a foil-based package. And you can see why. That's to keep that stuff from bleeding through paper. There have been EMTs and paramedics who think that package itself is the occlusive dressing and will just put that on top of a patient. You have to open it and get the real dressing out. And it's because textbooks will take a picture of that not opened. And I guess they do it because you would have a hard time determining what's a real dressing and what's a dressing with Vaseline in it. I don't know. Open the damn package. Get it out. When it comes to chest wounds, we are concerned about it sucking air in here instead of the normal pathways. So that's why we seal it with an occlusive dressing. However, Your textbook says to tape that down on 3 sides. Leave the one side open so it's a flapper. So when you inhale, it seals. When you exhale, it will let the air out. So if there's any trapped air, it will come out. And that's supposed to act as a valve to help reinflate the lung. Have you ever tried to put tape on Vaseline? So somebody had this great idea in the book that says tape it down on 3 sides. Well, what ultimately happens is the blood, the Vaseline, the stickiness that's all involved there, that 4th side will just stick down anyway and won't lift up when it needs to lift up. We'll talk more about that in chest trauma, on how to manage that appropriately. But please understand, neck wounds, even if it doesn't involve the airway and it just involves the tissues, the soft tissues, and occlusive dressing. And you need to know why. Your jugular veins, especially the external jugular veins that are closer to the surface of the skin than the internal jugular veins. Remember when we looked for JVD and I bared down up here and made them stand out? Why did I have to bear down to make them stand out? Well, because normally they're under negative pressure. They're just draining. They're just draining the brain. So if I open that, it's just going to drain out. Below it, say it's cut right here, below this, the blood's going to drain, and as it drains, what is it sucking in? Air. So I have to seal neck wounds with an occlusive dressing as well. If your guts come out of your abdomen, they get sealed with an occlusive dressing. You probably don't have a piece of Vaseline gauze big enough to cover the entire abdomen. For that case, you can take what we call abdominal dressings. Those are great big pads, and then soak it with saline. Putting that water on it will make it an occlusive dressing, and it'll keep it moist, which is what you want to do to those innards, those guts, those protrusions. You don't want to try to push them back in. And you may have people walk up to you holding them. Do y'all remember the old way the Indians would torture someone? They would cut them open and they would tie their intestines to a post and they'd set the post on fire. And you had to back away from the post because it was burning you as it pulled your intestines out. Never heard that story? The things you learn in EMT school, right? That is brutal, isn't it? That is brutal. Which one?
Like a little tiny pyramid.
Oh, yeah.
That big, and they sit you on it, and they tie both your legs down with weights, and they make the weight heavier and heavier.
The turn of the screw kind of thing under your fingernail. You will talk. You will talk. Luke's over here looking at me like, you don't even know. You don't even know. So we talked yesterday about direct pressure, pressure points, splints, and tourniquets, so no issues there. Splinting if there's a fracture, and there's an example of some abdominal evisceration. Abdominal evisceration. Relatively young person, I'm guessing. I don't know what type of mechanism of injury caused this to open here and this to open there, but it's present, and it's under pressure and it wants to come out.
So you just put an abdominal patch over there?
You cover that with a occlusive dressing, and in this case it's either a piece of saran wrap or more likely a big, what we call an abdominal pad, abdominal dressing. Put it on there and then just dump normal saline on it. Nope, don't try to push them back in. Just lay it over there. If they go in on their own, okay, not a problem. But we don't try to shove it back in. Which is really ironic. If you've ever watched abdominal surgery or anything where they take all of that stuff out and work on something, when they go to close you, they just rake it off in there. It just literally just rake it off in there. Yeah, it just kind of sorts everything out. And you're like, oh, damn, can't you try? Can't you even try to put the right side on the right side?
How would you know?
I don't know. There is risk of lacerating these intestines and then the contents of those intestines causing wound contamination itself, depending on what part of the intestine. But if it's the upper intestine, it's going to have a lot of digestive enzymes. Lower intestine, it's going to have a lot of waste. So you're going to be containing that anyway. Y'all like?
At the top, is that more?
Is that what?
Is that more intestines at the top?
Uh-huh. Yeah. Yeah. Notice there's not a lot of bleeding though.
I was curious about that.
There's not a lot of bleeding with these. There's not a lot of, have you deer hunted or anything? So when you open that deer up to gut the deer, if you will, field dress the deer, I guess would be the proper term. You notice there's not a lot of blood inside the mesentery or the abdominal sac. The peritoneum, if you will. There's not a lot of blood in there. There is gas in there though, right? You will smell that. So there's the example there. They got this big piece of gauze and then they just soak it with normal saline. Are y'all familiar when I say normal saline, what I'm talking about? It's sterile water, but it's got 0.9% salt content. And that matches the salt content of your blood or your eyes or the ocean. Ironically, the ocean salt content and your blood content's the same. 0.9%. Huh?
Is it just ocean water?
Seawater, yeah, seawater has the same salt concentration as your blood, unless it's the Dead Sea. Half normal saline is 0.45%.
So if you ever like your guts cut open in salt water, you might not die.
It would be better for it than fresh water, because in the fresh water, your cells are going to soak in the water and expand. That's why you don't put the amputated part in a bucket of ice water, because it will expand. You ever put meat in ice water for whatever reason? You ever go camping and your lunch meat gets in the ice water? It swells up because that salt in that meat absorbs the water, makes it gross. Ding ding. Rule number 5,000 of today. If it's impaled, it stays impaled. There is a test question that I wrote. You won't see it here, but you might see it in paramedic school. You have arrived on scene of someone who has been stabbed in the back. He is unconscious, unknown. He's unconscious, no pulse. You need to perform CPR. How do you do it? And I've got some really crazy stuff written in there. I'm kind of like, perform lateral side compressions. People will pick it. Look for DNR. People will pick it. Don't think the DNR is applying here. Number 3, remove the knife, roll the patient's spine, and begin compressions. That's the correct answer. And I don't remember what I got for number 4. But the point is, it's impeding treatment, so you remove it. Now, a lot of people miss that because Billy, in EMT school, somebody sat up here in the pulpit, swinging the gavel, saying, never removed an impaled object unless it's in the airway. And the example they give is a pencil in the cheek. I have never found a pencil in the cheek, but I have found plenty of knives in someone's back. People just don't really get all domestically pissed off and use pencils to shove in your cheek. It happens in 3rd grade. I've never seen it happen in 3rd grade. You have?
No.
Oh.
So if they have a knife in their back, so would you lay them on their side to transport or on their stomach?
If they were still conscious? No, I would not put them on their back.
No, like on their stomach or on their side?
Usually the rule is injured side goes down. So if you're going to transport someone that's got an injury on the left or right side of the body, we'll usually transport them with the injured side down. That way the left side can still breathe. Does that make sense? If I compress the left side and they got a wound to the right side, It sounds counterintuitive because, like, man, won't it hurt laying on it? Well, it's hurting anyway. You got to at least breathe. If they're unconscious, they're probably on their back. But we're going to remove that knife if it impedes providing CPR or life-threatening deals, okay? So all those rules, Billy, there's exceptions to all of them. Cheek or mouth obstructs the airway. But they always use a pencil. We already talked about neck wounds, occlusive dressings on neck wounds, right? Do not impede the trachea. In other words, you can't tie a tourniquet on the neck. If you need to hold pressure on a dressing on the neck, you probably saw some techniques with the Israeli bandage. Another thing you can do is you can put a C-collar on. And the C-collar could act as the bandage to hold the dressing in place. Cool? All right. I don't like C-collars for what their intention is, and that is trying to prevent neck trauma. They actually cause more distraction injuries than that. But they hold the head steady. So if I'm wanting to keep an intubation tube in place, I can use a C-collar. If I want to hold a dressing, I can use a C-collar. Number 5042, ding ding. Animal bites must be reported to the authorities. That includes human bites. Humans are animals. Human bites, animal bites must be reported to the authorities. The authorities are monitoring infectious disease transmission, like rabies and syphilis and things like that. Human bites happen to be some of the nastiest bites you can have. Probably much nastier than a dog bite. And you're like, no way. Well, the enzymes in dog saliva versus your saliva is a lot different. That's why dogs will do things with their tongues you won't do with your tongues. The word debridement. You might become familiar with that word. That means surgical removal of dead tissue. Debridement. That word right there. Looks like debridement, but it's debridement. That is surgical removal of dead tissue. You will transport many, many people for that procedure. Usually out of nursing homes with bed sores, also known as cutaneous ulcers, pressure ulcers. This is what happens if you leave someone on the backboard too long. You could get pressure ulcers that require debridement. A diabetic who bumped their toe or has an ingrown toenail and has an infection and they're not aware of it, and they go get that cleaned up, that's called debridement. Medical maggots perform debridement. So maggots in a wound will only eat the dead tissue. That's a form of debridement. That avulsion that you have on your arm or your hand and that flap of skin that won't stay down and it gets infected and dies, the surgeon or the physician who cuts that off and cleans that up is debriding that wound. Antibiotics are a no-brainer. Tetanus prophylaxis, they'll give you a tetanus shot prophylactically. Tetanus bacteria live in anaerobic environments. So the deeper the puncture wound, the more likely for tetanus to propagate in that wound. Abrasions, surface wounds, tetanus won't live there. Tetanus dies really quick in the presence of oxygen. Now the sporum, it can live in the environment in a really long time because it lives as a spore. And you step on that rusty nail and drive that spore deep into your foot, the likelihood goes up versus getting scratched on barbed wire. Prophylactic means prevention. So they'll give you the tetanus shot just to prevent it. And routinely you should get a tetanus shot every 10 years. Anybody really know what tetanus does to you if you catch it, if you acquire it?
Makes your body seize up.
Makes your body seize up? What do the old timers call it?
Lockjaw.
Lockjaw. You die because you just locked down and you don't breathe anymore. It causes this constant contraction. There, many cases of people having it, and the contractions are so strong it breaks the bones that the muscles are attached to. You just extreme muscular contraction.
Is it messing with your nervous system or your skeleton?
Nervous system.
Isn't it just whenever like bacteria gets
The tetanus toxoid gets in your bloodstream. Anaerobic bacteria, though, it thrives in an anaerobic environment. So a wound that's deep, that doesn't reach the surface, or no air from the atmosphere can get to it during its growing stage, is where it does it. You can get the tetanus shot, the tetanus vaccine, and it will have an effect and build antibodies before the bacteria will begin to get into its infectious stage. So that's why it's just a routine tetanus shot. If you go to a disaster like the hurricanes in Florida and the Southeast, if you ever go to one of those areas as EMS, and high likelihood you will, it's probably a lot of what you'll be doing is just standing in a clinic or a mobile clinic or driving by giving tetanus boosters to people because they're in these wreckages, all this debris. And to prevent widespread outbreak of tetanus, you'll just go by and give tetanus shots. Or debit cards. I knew a crew that went down to Katrina, and their role was passing out debit cards. And another guy knew about it and was following along in a pickup truck buying those debit cards for 50 cents on the dollar because the people would rather have cash. So he was doubling his money, and the people were happier. So it went from one pickup truck that was full of cases of debit cards. How many are in your family? 5, 7. They just passed them out according to how many people claim were in their family. A block away, the guy was like, I'll give you 50 cents on the dollar for that card. And they're like, hell yeah, I'd rather have cash in this card. Where am I going to use this card at? So he filled his pickup truck up with cards as he passed out cash. Your tax dollars at work. And so when I see the politicization of a disaster like you see going on right now, we only get this much money, you only get this money. We really know what's happening. There's somebody down there buying those cards. It's crazy. Crazy, crazy, crazy. Do y'all know what rabies will do to you? It's also known as hydrophobia. It's the fear of water. And you got to get those 75 shots that your mom said in your belly. I think it's more like 4, 5, 6 shots. I don't think it's 75 or 62, and they're not necessarily in your belly.
Don't they say once the patient's scared of water, they're too far gone?
Yeah, once you start foaming and you're going away from it, yeah, your brain's fried. It affects your nervous system as well. The virus causes rabies. So be careful with that. It is a series of vaccines, but it can be prevented if you get there in time. If you get there in time. Animals that are nocturnal, that bite patients during the day, the likelihood goes way, way up. By nocturnal animals that are usually only active at night, but are out during the day, those are the ones that cause the most concern. Bats, skunks, all those different things. So we already talked about the human bite, must be reported. Okay. This will probably close out the morning as we talk about burns. I've already mentioned earlier that burns are disfiguring, they're painful, they're hard to heal from. They're obviously life-threatening in certain areas. They're difficult to manage because they get worse over time. The burn you see upon your arrival will not be the same burn you see tomorrow. If you're in a facility to where you can see your patient's progress, you will not recognize your patient that you took in yesterday. I think this is a great mechanism for air transport because these patients are not done any service by being transported to a facility that cannot manage the burn. unless it is an airway rescue situation, they're better off spending the time and going on to the burn centers. Your EMS agencies locally may not want you making that ground transport, and your patients will be better off going. If these burns are severe enough, it is ethical, moral, and every other righteous thing to do to put them out of their mind. Use sedative, dissociative, hypnotic agents such as ketamine. Put them in the woods with their favorite comic book character or movie star. Let them go into dream world while you manage their physical being. That's highly important. Secondary to that, if this looks like there's a high incidence of fatality, it is ethical and moral and every righteous thing to do to maybe notify or get a family member on scene to have a conversation while you're preparing the drugs. And you say, I'm an EMT, I don't do all that. You're the one starting this process in motion. So yes, you will do some of it. Your paramedic may be busy with the drugs in the airway, and you may be dealing with a family member. I think we have a tendency just to grab and go with these people, and I can understand that, but I think you also need to take the moral implication into account. If that paramedic puts him or her to sleep with these drugs, which they need to do because it hurts so bad, and I need to get an airway secured because they have soot in their mouth, they got charring of the tongue, that's only going to swell. So the paramedic needs to get that tube into the throat, into the larynx, into the trachea before the swelling gets so severe they can't do it. So we're going to take away their ability to talk, take away their ability to be conscious, take away their ability to tell you goodbye. Give that patient that opportunity to do so if they can. They're going to be hoarse. They're not going to speak clearly. They may be coughing. But in all reality, that's probably the last time they'll talk. You just want to be honest about it. I don't think we do a very good job of that. And fortunately, because of the latent heat of vaporization, that's a physical law that says water is real good at putting out fires, and we have a lot of water in our mouth, we don't see it that often. Even though it may look really bad, that's why you can drink hot coffee but not pour it on your skin, because water in your mouth does such a great job of absorbing those BTUs. But when it does happen, it's usually fatal. When it gets that bad, it's usually fatal, because by that time we've got a lot of heat being absorbed, Frank, the energy being absorbed faster than the body can handle it. Burns are ugly. The lifespan of a burn center nurse is about 2 to 3 years, and they go on and do some other form of nursing. People who go to burn centers get debrided once and twice a day. They go to the wash tank and they are scrubbed with nylon brushes like you would scrub the wheels and tires of your vehicle to debride all the skin and tissue that just keeps sloughing off, and then it gets rewrapped. Once that sloughing stops, now they can do a skin graft. So these people are down here for 30, 60, 90 days. The nutrition requirements are up 10 to 15,000 calories per day. The fluid requirements are astronomical. The IVs may not be able to be inserted in normal places because that tissue's burned away. May have to go in the neck or a central line.
So that's my question. Say you get a patient who's burned really bad,
Uh-huh.
and you can't get an IV.
Somewhere you can, or we'll drill the bone.
Drill them.
Yeah. Somewhere you can, or we'll drill the bone.
If you come across a burn victim and they're like begging you to like
Kill them.
yeah.
We have drugs for that.
Can you actually like
Euthanize them?
yeah.
Don't say that.
That's essentially what you're doing.
I didn't know if like you were still supposed to
When I teach medical ethics, which I don't do much of it anymore, but perhaps I should do more of it. Let's go back to our scenario that a firefighter You're on a fire crew. Your fire crew is also paramedics. You know, you're working at that department that everybody's everybody. You're doing an interior attack on a fire. There's a collapsed ceiling beam. It knocks off your SCBA mask. You inhale superheated gases. You take burns to the face. That person is rescued. The other firefighters pull him out or her out. We put them in the ambulance, and we're looking at this, and we got this superheated gases going. So when the superheated gases get down into the alveoli, they just turn them to glass. They just wipe out your alveoli. Plus all the toxins in the smoke that's going along with it get absorbed into the system. This patient is in bad way, and we need to put that tube in immediately if there's any chance of survival. They're fully alert and conscious. They're screaming out in pain, obviously. They probably know, if they're a firefighter, what the implication is here. I'm probably going to die. So why not go ahead and do it? And you may hear that. So we're going to treat this guy with ketamine or some other dissociative anesthetic. Ketamine comes to mind easily. There are others. We're going to put them in la land. We're going to take the mind out of the game. We're going to separate the mind from the body. That's what the dissociative property means. We take the mind from the body. People who take those trips actually think that they're leaving their body behind and going to a better place. When that happens, we're going to paralyze the patient. So they can't move, can't fight, can't twitch, can't do anything. Put the tube in their mouth, start breathing for them. All the while knowing the paramedic or paramedics who are doing this procedure on that person, they know that this patient may never wake back up and probably won't wake back up. And so the moral, ethical, bioethic question is, are you euthanizing them? Is the term euthanization to take a living creature out of its misery by creating death? Well, you didn't kill the patient. You're trying to keep them alive. So it's not euthanizing. It's not euthanizing them. It's doing the right thing to do, even though it will probably result in death. It wasn't your action that resulted in death. It was the previous thing. But it is eliminating suffering. And so that piece of euthanasia, that piece of that definition is present. You are eliminating suffering. You are eliminating suffering. And you could think about that too much and really get yourself in a position, but we can't use that word anymore, or if we ever could. Yeah, if your indication for taking someone out of the game is because I wanted to remove their misery, that looks too close to that definition. In order to provide adequate treatment for the respiratory burns, 100% yes. And nobody wants you digging around in their mouth with a laryngoscope. No one wants to be paralyzed and yet fully conscious. You know, we tiptoe around the fact just to make ourselves feel a little bit better. Hospice, liberal use of the drugs. Now, we can't say we're giving them the drugs to stop the breathing, but liberal use of certain of those drugs can stop breathing.
Do you up your doses of ketamine on those patients?
On like the burn patient? But the dose is the dose, so the dose will do it. I mean, if I'm ever using ketamine to induce a dissociative property, I'm going to use enough to do it, regardless of what's causing it. But the dose that are in those protocols for that is plenty. Some say it's way too much. Anyway.
That was supposed to, we never gave enough in the ER. There's statistics showing that we don't fully intubate people, but like
Fully sedate them?
Fully sedate them in the ER. That's why they're, you hear a lot of people when they wake up afterwards.
That's criminal. That's criminal. They wake up should not remembering anything that happened to them.
We had this one doctor, his name's Dr. Rowe. He always gives them more. Like the normal docs give them 100 mics of fat and 100 mics of ketamine or whatever. He gives them 90.
If I've got airway control, there's not a problem with giving them a little more. there's no hard dosing on this. Some people have more tolerance, less tolerance. You know, Jonah, to all of you, the idea of giving that is they know nothing, whatever dose that takes. And once you paralyze them, you don't know if their mind's in the game or not. Did I tell you the bull riding? I told you the bull riding story in Durant.
We maybe
It's-
talked about that.
We've talked about a lot, and I told a lot of stories, and I tell a lot of stories year after year, but these kind of stories are driving the point home. About the kid at the high school rodeo riding a bull. I did not tell you that story. All right. This kid was in a high school FFA sponsored rodeo. And they weren't riding bulls, they were riding steers. Bucking steers. This high schooler got on a steer, was thrown, and was stepped on right in this area, right upper quadrant, right lateral chest wall, stepped on by the thing. EMTs and paramedics on scene? Sure. You know, you got to have them there. So they go out there and they get this kid. And think about it, stare it. You've been stepped on right here. So what's there? Right upper quadrant. Lungs, liver. Lungs and liver, two big critical things for life. And they're potentially damaged by this. This kid's screaming out in pain. He's having trouble breathing. He's tachycardic. He's scared. He gets in an ambulance and they go to Durant Hospital. In the hospital, they get the report. Kid's been stepped on by a 1,000-pound steer, blah, blah, blah. And now he's got upper quadrant pain, rib. Oh, shit. We're not a trauma center, but we'll look at you. They go in there and the physician says, this guy needs to go to OU, Oklahoma City. Needs to go trauma center in Oklahoma City. Get a helicopter here. Okay. Sure. Sounds good so far, doesn't it? I totally agree with everything so far. We need to get this kid knocked out, prepare him for the helicopter ride because he's flashing, he's flopping about, he's in pain, he's scared. Let's do this procedure and put a tube in his mouth. So they do. He's flaccid. He's got a tube in his mouth. They're breathing for him. Parents are there. They're waiting on the helicopter. The helicopter crew comes into the room, and I don't know if you've ever seen them come into the room or not, they repeat everything. They just don't take you and go. They don't listen. I mean, they listen to a report, but they still repeat everything. If they say you got an IV in the right arm, they're going to look at the right arm, make sure the IV is good. If they say you've been given this much medicine, they're going to check that and make sure it's good. They're going to do their own assessment because it's about to be their patient at a couple of 1,000 feet in the air for the next hour or whatever. They do their own assessment. So they're running through the charts and they're like, they ask the nurse, what did you sedate him with? I don't see it in the report. And she said, oh, we used succinylcholine, and now he's got rocuronium. And they're like, but what did you sedate him with? I know what you paralyzed him with. I see that written here. So, oh, that's what we gave him for sedation. And here comes the doctor in here and said, what is the delay? Can't you see this kid's going into shock? Look at his heart rate. It was 120, now it's 140. Get him out of here. And they're like, understood. Understood. So they take him out the helicopter.
They said they didn't know.
And on the way to the helicopter, the flight medic took out of his little flight uniform a vial of Versed, pulled up some Versed, shoved it in his IV, and his heart rate went to 80. The kid's awake the entire time all this is going on. And he's hearing all of this. Liver laceration. Got to go to surgery immediately. Don't hurry up, he's going to die. All this stuff. No wonder his heart rate's 140. That's the only way you can tell his brain's in the game. Could also misinterpret his shock. Fly him to Oklahoma City. Because they're not going to turn down a flight. They fly him to Oklahoma City. So his parents drive to Oklahoma City. You see this unfolding? Middle of the night, we're on the way to Oklahoma City. What are the parents thinking of the 3 hours it takes them to get to Oklahoma City?
Is she gonna be alive when I get there?
Is he going to be alive when I get there? Or are we going to lose our son? Flight crew delivers him to the hospital, Oklahoma City. They shoot some films, do some scans, discharge him with bruised chest wall, contused chest wall, not even any broken ribs. Contused or bruised chest wall. The kid is upright, waiting on his parents in the waiting room of the yard when they arrive there. Here's the bullshit. Here's the bullshit. If it all hadn't went that way, our son would have died. Thank you, staff at the Durant Hospital. Thank you, flight crew at the Durant Hospital. You guys are wonderful. How much was that bill? We'll gladly pay it because we have our son. You just tortured that child. You should be sued. You should be sued for cruel and inhumane punishment. You paralyzed someone, stuck a tube in their throat, and you didn't take their mind out of the game. You did not realize, because you were so poorly trained as a physician, you weren't trained in emergency medicine. You are a family practitioner who's trying to pay student loans, and you're taking a $75 an hour job at some hospital as an emergency room physician. That's what you get when they're not designated trauma centers. Hey, I just got out of med school. I need to do something. At that same hospital, I have worked codes alongside physicians who didn't know what the hell they were doing and go, don't tell anyone, but stand here with me and tell me what I should do to work this code. I just got out of med school last year and I've never even intubated a patient. I don't know the drugs for resuscitation. Don't leave me, please. Okay, sure. I've been in Bonham Hospital where the physician says, when an ambulance gets here, the level of care in this hospital goes up. Please help me. What do I do to stabilize this cardiac patient before I go down? I would order some heparin. I would get a 12 lead. Let me interpret the 12 lead. Let me go talk to Baylor Heart and tell them the interpretation of this 12 lead and what the patient condition is. And you're doing that as a paramedic, not as an ER physician. I've walked in there, hurry up, get here. I can't get this patient intubated. You've already dislocated his jaw and broken out both teeth trying to do it. Both front teeth by prying back, and the jaw is now dislocated and floppy. And you want me to clean this up now? Sure, because we do this in car wrecks and other things. But this guy was okay till you decided, well, I had to do it because I paralyzed him. Have you sedated this poor son of a bitch? What do you mean sedating? You just dislocated this guy's jaw and broke out his front teeth, and he's fully awake. He's listening to us.
You can feel it too.
And he is suffocating. Oh yeah, it doesn't take away pain. The paralytic drugs do nothing for pain. And you want to tiptoe around some effing trivia, Billy? You want to tiptoe around what's different between an urgent move and an emergent move? How about we understand what the hell we're doing? Oh, that would be a marvel, wouldn't it? It's dangerous. It's a dangerous bag of tricks, and we turn these physicians out with these bag of tricks. I'm not saying all physicians are bad, but our medical system allows someone who's had no ER experience in emergency rooms making these decisions, and they make the final decision. And then they argue with you when you go, you have to sedate him. I did what sucks. Do you realize sucks is not sedative? It's botulism's cousin.
Can you ever take the patient back?
No, they're yours.
No, I mean like, you get to the hospital, you realize that your dog's like an idiot. And I'd be like, just give me the patient back, I'll go to a different hospital.
Nope, it's abandonment. It's abandonment. They're not going to turn them back. They'll have to go through the system and arrange a transfer to go somewhere else. This is what I'm saying is, if your system will allow it, transport these patients to, so if, just say you're in a small local hospital that doesn't have any burn center or emergency room experience. What good is it to take a burn patient there? You can interrupt this nonsense process by going to the most appropriate facility, in every law in the book. Transport your patients to the most appropriate facility. Okay? It didn't say how long it took to get there. Now, if they can go to some hospital before the appropriate facility to get more care than you can give, absolutely. Stroke, for example. I can't start clot busting drugs, but they have a CT scanner and they can start the drugs, and then we can go on to a comprehensive stroke center if needed. That's different. But if I've got a burn patient with critical airway burns, there is no reason to go to a hospital that can't manage that, unless you can't manage it. And that level of education, that level of knowledge and competency is undermined in our own profession when we allow people who don't know what they're doing to serve in our capacity. So we can blame the ERs and the physicians and the nurses all we want. We got some yahoos too, by God, that have no business having those drugs at their disposal. So we're all guilty. And it's not enough, Billy, to know the difference between emergent and urgent move. You know what I'm saying? It's not enough to pass a course or not pass a course. And I had a student come from your same school who made it last year, who didn't make it in that other school because he missed a test question on what the most effective way for disease prevention was. And the correct answer is hand washing. He picked hand sanitizers. I wonder why, since they're at every door of every place there ever was. He's like, well, apparently that's important. So he picked that instead of hand washing. And they did not let him complete the course because he missed by one question.
You said hand wash, right?
Yes.
So in the other class, they told us like best prevention would be like, your shots. And then a handful of the students picked hand washing, and then they tried hooking it into
Go pet your dog or something. I don't know. Removing, killing and flushing the pathogen from your body is the best. If flu vaccine worked, there wouldn't be any flu. We eradicated smallpox. There was a documentary where the physician gave the last smallpox vaccination to a child in a third world country and said, with this shot, I eradicate this disease from Earth. This menace from Earth. Push the plunger, please. Except for the ones in the lab. Because scientists can't knowingly get rid of any species. So we kept it in the lab, and it's out again. Somebody got it out of the lab. That vaccine works. Flu vaccine doesn't work because we can't get in front of it. And we can't get in front of it, and it's not always effective in the organism. You know what I'm getting at? It's not a vaccine because it has such low efficacy. Yes, hand washing. Hand washing. If you got it on you, you need to get it off of you. Not allow it to go into you and see if your vaccine worked. If you're going to prevent Hep B, would you rather be not injected with Hep B blood or wait to make sure the Hep B vaccine worked for you? You got two choices to prevent Hep B. You can take the vaccine and let me inject you with it, with blood contaminated, or you could just not be contaminated. Which would you prefer? Yeah, exactly. Hand washing, flush it off. Point is, this guy knew the material. It was a non-valid question. And this process of giving you test questions that are, one, reliable and valid, they ask the right question to the right objective. And if you're going to a school where all tests are printed by publisher test banks, you need to get the hell out of there. Because they're going to fail you and or pass you, fail or pass you on non-valid reasons. Obviously, that test question is not valid. But nope, didn't meet my standard. Didn't meet my standard. Sorry about all that. Sorry about all that.
I like to see your veins. bulge.
You like to see my veins bulge? Well,
We should take the blood pressure.
Yeah.
it's probably really good. It's probably really good. I got that off my chest. It was coming. All right. Back to burns. If you look at the burn criteria sheet at the back of the classroom, you also see some ages. The old and the young. To grow old is to grow young again. These people can't compensate. And I promised you this. It has to do with BMI and BSA. BMI, BSA, body mass index, body surface area. Or another way to write this is body surface area to mass ratio. Body surface area to mass ratio. So a young, when I say young, a young adult, a young, vibrant adult in the prime of their life, they have more mass than they have skin. There's actually a formula. I can take your weight and your height and I can tell you how many square meters or square yards of skin you would have. If I wanted to make a rug out of your skin like that guy in that movie, I could tell you how much skin we would get.
All right, Professor Don.
Yeah, what was that guy? Silence of the Lambs. We can see how much skin you have. That's called body surface area. And the rule of nines, which is also on that piece of paper, is taking that into account. So 9% of your skin as a young adult is different than 9% of a child's skin, a baby's. And it's not so much that as it is compare that to how much they weigh. That ratio gets off. The young, vibrant adult like you has more mass than skin. A child has more skin than mass. So when they burn off 9% of their skin, they don't have enough mass to compensate for the heat or the metabolic requirements needed to keep that organism homeostatic. The young adult may do so. You go to the old population, they lose mass. They lose muscle mass. That muscle mass generates heat, generates metabolism. The muscle mass is a great insulin storehouse, makes them insulin sensitive, blah, blah, blah. They look like a child with that body surface area to mass ratio. Does that make sense to you? So the old and the young are more susceptible to burns because of that mathematical ratio right there. Secondary to that, they don't have as good of immune systems. They got immature immunity or dying immunity. They can't consume enough calories to recover from the burn. Old people don't want to eat, young people can't eat that much. So there's a lot of reasons stacked against that. In the really young people, they can't tell you when they're hot or cold. So temperature regulation becomes an issue. Old people may not be able to tell you whether they're hot or cold. And when they get the burns, they may not have the mobility to get away from the source. If an old person or a really young person falls into scalding bath water, they may have a hard time getting out of it compared to you getting in scalding bath water. That makes sense? You're a little more instinctually able to manage daily life than the really young or the really old. Get them to the appropriate facility. And we already know this. You're transferring some form of energy into the skin faster than the energy can be absorbed, whether it's laying out in the sun or being exposed to superheated candy. Some of the burns I've seen were people who work in facilities where they wax body hair off of other people, and that wax gets too hot, especially if they heat it in a microwave. Heating stuff in the microwave is really, really dangerous. Trying to heat water up in the microwave, and you look through there and it's like it's not boiling, it doesn't look hot, but as soon as you open the door, it will splash steam on you, because it really didn't have that first piece of catalyst to boil from. The way it's heated is not from the pan. Microwaves heat by exciting the molecules, and the water molecules are just sitting there like, well, what are we supposed to do? And then when that air gets to it, it's like, oh, there's a piece of dust in the air to build off of. Flash burns, steam burns to the face. Candy. Oh, candy's terrible. Thanksgiving, Christmas time, grandma's gonna make some candy for you. You love that fudge, you love that toffee. She's heating that sugar up in that pan, constantly stirring, and it falls off the stove and catches her on her legs, and it's very viscous. It means it just sticks and holds. Industrial, oils, greases, hydraulic fluids that get super, super hot during the machine process and operation. A machine operator has a hydraulic line blow apart on him. You're baling hay out there. The hydraulics get super hot. There's a fire in the baler. The hydraulics rupture. 22 to 3,000, 4,000 pounds of pressure blows that hot hydraulic oil all over your body. It's very viscous. It sticks. It just keeps burning and keeps burning. That's how skin gets burnt. It just getting the energy faster than it can get rid of it. People reflexively limit heat energy and exposure time. They cannot do so if unconscious or trapped. Is there fluids in car crashes? Are you often trapped in car crashes? So you may see a lot of burns secondary. May not even be hurt because of the crash, but because of the heater core that was in the dash ruptured, you get the burns. Yes?
With that, like you were talking about the candy, or whatever the hot substance, sticking to the skin, do we remove that or do we let the hospital remove it?
Okay, great question. His question is, if that substance is stuck to the patient, what do we do? Two things. Number one, stop the burning process. And that goes for all burns. Stop the burning process. Number two, decontaminate. And if those happen side by side, awesome. Get it off. You've got to cool it. Cooling it is stopping the burning process often, right? And decontamination is a must. Up into the point where we're starting to cause tissue damage to the removal. And then we stop. Once we start, in effect, removing tissue because we're that aggressive, we stop. As long as you get it cooled off, though, we don't really care if you're covered in sticky candy. It's probably going to fall off anyway because it's just burning the tissue away. So the stopping of the burning process often results in decontamination as well. With that, hang on a second. With that being said, if I get a dry chemical on my skin that's burning, but I add water and it gets even hotter, then I have to take the chemical off before I flush it with decontamination.
So what if it's something that like hardens up after it dries and it's still hot? Do you
Like
just
tar?
and leave it?
Like tar? Yeah. Like asphalt roofing tar? What's on the road, stuff like that? Stop the burning process. You got to remove the heat. You got to get the heat transfer going somewhere else.
That's what I'm saying, you just cool it off.
Yeah, and if it's there, it's there. Because it's going to slough off anyway. It's going to slough off anyway. The burn center people will scrub it off. And I paused on that story, but they're going to get them in there and debride it, and they're going to scrub those brushes, and it's just going to bleed, and the patient's going to scream out in pain, and you can't give them morphine every day. Most burn patients end up as drug addicts. I've known just a handful of people who've had to spend time in a burn center because of burns, and they tell me stories of like, I had so-and-so sneaking me Vicodin in there. I would ask for a Dr. Pepper and a cheeseburger from Sonic, and they would put the Vicodin tablets or whatever pain-relieving tablets in a baggie inside the drink of Dr. Pepper so I would beg them to bring them to me because the burn center says you can't have any more. Begging people to smuggle in narcotics for pain relief. And a lot of these people come out of there addicted. And they're disfigured. And these skin grafts are weird. The whole process is just a horrible, horrible process. So if there was anything we could stop, I would like to see us stop burns. We already know this, so we can move this relatively quickly. You've opened them up to infection. They're no longer able to control their heat. So one of the first things we'll do on scene with a patient who's been burned severely is we got to preserve their body heat. Sounds very counterintuitive. Heat's what got us here. Yeah, but after you've stopped the burning process and you flushed them with water and you've decontaminated them, now you got to keep them warm because they can't keep themselves warm. If you see a burn patient chilled, because their skin is no longer able to regulate that heat. There is going to be a massive fluid shift. It's called blisters. It's called. Do not intentionally pop blisters. That's nature's perfect burn cream. That's full of antibodies and white blood cells and leukocytes and all these things that are just perfect for healing that skin. It always got me when I'd see an athletic trainer pop somebody's blisters on their shoes so they could go back out and play. What are blisters on your feet from shoes?
Friction.
Energy, heat, building up, causing a burn. That fluid that your body secretes and makes that blister with is nature's perfect burn cream. However, if those blisters or that edema goes around an extremity, we call that a circumferential burn. The word circumference, to go around. So if I've got a burn on my chest that goes all the way around my chest, can my chest expand for tidal volume? No. New word alert, Jordan. There is a term for burns that turn your skin to leather. Your skin gets this leather-like appearance. Really stiff. You're actually tanning your hide, if you want to know the truth. You're tanning your hide with heat. That term is called eschar. S-char. There's a reason char is in there. Usually seen in your third-degree burns. If you get that eschar or you get that edema around an extremity, if it's around the chest, no chest expansion. If it's around an arm or a leg, what's happening distal? Compartment syndrome. In order to prevent that or relieve the chest constriction, we perform, paramedics do it, ER docs do it, escharotomy, which is they take a scalpel and they will slice through that charred skin to allow it to expand and breathe. It's called an escharotomy. EMTs don't do it, but if you see it, you know you need to get ALS involved or quickly to a hospital because it's limiting your tidal volume, and it's only going to swell and constrict more and more and more as time goes on. So with that escharotomy, what have you just opened them up to? Infection. So it's a major process trying to get someone healed. It's just not an easy, oh, you got a burn, now you can do this. If you got a totally submerged hand in hot oil, are you going to have those escharotomies on every finger, possibly? Yeah. They'll probably hold your hand up in the burn center and put a drain down here in your arm, and all the contents will run through a surgical drain, and you lay there in bed the whole time with your arm up. Mm-hmm.
What did you call it? A
Circumferential. Circumferential. That's all coming from that massive fluid shift. And getting fluids back in their body, paramedics need to be there to start IVs. They will calculate how much fluid to give. BLS people don't do that, but you got to recognize that they need the fluids replaced early. The IVs need to be started early too, because sometimes what's not swelling now will in the next 2 hours. We know to use extra long IV needles, so when it does swell, it still stays in the vein. It's a complicated process. Thank goodness for IO needles, so we can get that fluid going through that way as well. And then ultimately, because of that fluid shift, it results in shock. There's that word, Amber, circumferential burns. And then this third bullet point's talking about compartment syndrome. It can press on it so tight you get nerve damage and things like that. The relief for that is the technique called an escarotomy. Hunter, that cyst on my cow's neck, the concern I have is that gets large enough that's pressing on the great vessels, pressing on the airway. And so, yes, that in essence is removing that pressure so the rest of the stuff can work. Questions so far? Okay. Burn severity. All this is summarized on that piece of paper. That's why it's hanging in the classroom. Burn severity. Major test questions out of this. Please refer to that chart. They're going to ask you a lot of questions about, does this patient meet burn center criteria? What are we going to base it on? Depth, how much, face, airway, hands, feet, genitalia, or automatic goes. If they have type 2 diabetes, they go. Why? Well, they have a metabolic disorder. They're prone to infection. They've already got capillary damage. Their type 2 diabetes rears its ugly head again. Younger than 5, older than 55, I guess I'm there. Damn it. For all these years I've been skating by. Now I'm old enough to talk about the old people.
How's it feel?
It sucks. It's depressing. But I do appreciate the wisdom. Because I hear the mistakes young people make, and I'm like, you dumbass. God, why didn't you come talk to me before you did that? I told you shouldn't marry her. And it's not her. Just put your life together first before you get married. It's hard enough without having your life together. Younger than 5, older than 55. There's some trivial aspects to the next 3 bullet points. I don't find this to be difficult at all. Some people make it difficult. I've seen the curriculum take away the words first, second, and third degree. I've seen them put it back. I've seen them say it's more appropriate to speak, is it partial thickness or full thickness? Guys, come on. We got bigger things to worry about than the semantics of what we're going to call this. Most of us, if not all of us, have had a first-degree burn. If you've had a sunburn, you've had a first-degree burn. If you've had a sunburn with blisters, it's second degree. It went down into the deeper layers. Third degree, I'd hate to lay in the sun that long that it burns all the way into the fascia, down to the muscle layer. There are people who will say there's a 4th degree and that's burning all the way to the bone. Okay, I think after 3rd degree we have enough tissue destruction. At some point we're going to debreed that back to something living. You will see people with burns so bad to like their hands that the only thing they've got left is the ulnar radius charge sticking out what used to be hands and forearms. Superheated furnaces, molten steel, molten glass, cardinal glass in Durant, that steel place in Durant. It takes 3 days just to get the furnace hot enough. They don't shut down. You dip a finger in that, it's gone. What about the guy at the Caterpillar plant who fell off in the molten steel? They didn't even shut down. They're not shutting down. For what? Why would they shut down? There's some caterpillar out here now that has the remains of some human in it. If anything was left after the vaporization, because when you fall in molten steel, you're not coming back. You can't shut it down in time to recover. There's nothing to recover. And we have those facilities locally now. Don't fall off in that pit.
What do you wrap the burn in?
Burn sterile dressings. And so that's a questionable point too that you'll see on the test. We wrap our burns in sterile dressings. we leave them dry unless it's less than 10% of the body. So if it's less than 10% BSA, we can moisten that with normal saline. But otherwise, it's a dry, sterile dressing.
Why is that? Why only moistening?
Because if I go more than 10%, the risk of hypothermia goes up. Yeah, it would be best if it stayed moist. No burn creams, no ointments, no grandma's margarine, no grandma's Noxzema skincare cream, no grandma's Decidin. Well, it worked on your little burnt butt when you had diaper rash. Maybe it's good for your burn. Anything put on a burn has to be scrubbed off in the burn center. Plus, it tends to hold heat in. No burn creams. No grandma's burn cream. So, first degree burn, there's the old sunburn. She laid out there on the first day of spring break, didn't she? Not a good look. This guy's got second degree burns to the chest wall, so those are very significant because they could become circumferential. And there's the charring escharotomy of a third degree full thickness burn. Notice they have him on respiratory assistance. They will probably come in and slice his chest laterally. They make some incisions up and down, and on the lateral sides to allow his chest wall to expand. And then you're just exposing raw flesh. Now you got another soft tissue injury, right? But you want them.
Is that like livable? Like, can we live?
We'll see.
That's what they had to do on his chest. They did.
Depends on what his odds are. You can't answer that question, Sterrett. How old is that patient? What otherwise general health is that patient in? What burned that patient? Is any of that inhaled? So on test questions, if you see anything about charring in the mouth, if you see anything about singed nasal hair or singed facial hair, it automatically becomes a high level burn center criteria because there's potential airway involvement. My very first summoning of a helicopter was a burn patient. In Howell, Texas, I was running ambulance in Van Alstyne, and we got the call for a propane gas grill explosion. I've got a propane gas grill. I know what happens, like you keep hitting the lighter button and it finally goes whoosh. But I always experienced that with the lid open. Apparently this guy experienced that with the lid closed. When his gas grill lit, do you remember the old Looney Tune cartoons where something would blow up and there would be this cartoon character who was white, and then they turned the next scene and his face was all blacked out and his hair was pushed straight back? Well, when I pulled up, I thought I had a black man who got burned. It was a white man who got burned. His entire face had turned black and his hair was blown back and stiffened like this. It looked cartoonish. And he was sitting in a lawn chair. And he had no lips and no eyebrows. This was all gone. He didn't have any eyelashes and his eyes wouldn't blink. And he said, I think I He was sitting in a lawn chair, stunned out of his mind. I think I screwed up. This guy was about to enjoy a burger or a steak or a hot dog or something, right? I'm sure he died. He was alive when the helicopter left with him. But I sat there with him and like, east side of the highway, 4 or 5 miles out. No, I'm not going to make it.
Is that how you looked? That exact pose?
Okay, yeah, pretty much. I'm just like, what do I do? Well, I was ALS.
What'd you do?
I got on the dispatch and I said, I need a helicopter, please. And make it quick. Make it quick. Yeah, it's just, they're horrific. They will stun you. You're like, oh my God. And then the smell that comes along with that burn, the smell of burnt flesh, the smell of burnt hair. They're so grotesque. And you really don't know what to do. I mean, you know they're probably going to die when they're severe enough burns like that. moving on along here, I need you to be very aware of the rule of nines. Now, there was a time in my life I let this go. I would not memorize the rule of nines. The rule of nines is a way to estimate body surface area involvement of a burn. I highly encourage you to become super familiar with it, and it divides it up in nines or multiples thereof until you get down to infants, and then it gets a little weird. Till you get down to PDs and it gets a little weird. But on the adult, 9, 9, 18, 18, 18, 1, 9. I like the rule of palms. The patient's palm is 1%. And so if you can kind of guesstimate how many palms it would take to cover their burn, that's an approximation of how much percent is burned. This does nothing for the EMT. I have never calculated this on a burn patient. I let old common sense come through. That's bad. That pose, that's bad. Right? I've never calculated this on a child who was taking a bath in the kitchen sink when the toaster fell in with him. And his mother got CPS called on her. I'm like, I'm telling you, it was an accident. The kid reached and grabbed the toaster. He should have never been in the sink next to a toaster. I don't think the mom had any intent. Leave her alone at least until this kid gets stabilized. But it was really weird because the burn came out of his mouth. I don't know why. Electricity does really weird things. He was burned at the corner of his mouth. Like he bit the cord, but he didn't. I guess that's where the water was, where the had a salt content. Electricity is weird. But that's where he had his burns. I'm like, no, he was in the sink. I went in the house. I saw this. She was giving him a bath. Johnson's baby shampoo, a little towel. She was going to bathe her child in the kitchen sink, and he pulled somehow the toaster got in with him. No. Maybe CPS needed to be called. I don't know. It's not my decision, but they were. I didn't call them though, and the yard doc saw it and said, "Get CPS here now." I'm like, "Oh, did I miss something?" Maybe I have. I don't know. I'm not going to quarterback myself. But I did not calculate this. If I'm having to give fluids based upon how much burn area is involved, I need to calculate this. Let me say this as a paramedic. The amount of fluid I'm going to give my patient while they're under my care will not be near what the burn thing's calling for anyway. So I'm going to give them all the fluid I can in the time I have them anyway. This just does not give me much to use. The utility of this in EMS is not good. But there are questions about it. I would just take my best guess and say, I feel like I'm going to do well enough on the exam. If I miss these questions, oh well, it's not that way anymore. They may ask you a burn rule of nines question. And remember the test. You get a question right, you get a harder question. You get that question right, you get a harder question. Until you get enough hard questions right. If you miss this question, it goes against you. And it may be the deciding factor for the exam. We'll talk more about the exam in December. I would not write this off anymore. It's still present. It's on that piece of paper back there. That understanding this applies right here. Understanding this applies right here.
What tries did we get on the registry?
3, and then you have to take a refresher. 3 more. And if you don't make it, you have to take a test. Or retake the class, I mean. So 6 total.
Doctor, did you fail the last test that qualifies you to take it?
Retake the class. So I'm going to leave that. I'm going to leave the lecture on that slide. Pay special attention to charring. When you read a test question, look for charring. So tomorrow's lab is probably a splinting lab. I'm hearing things that the uniforms are in processes of modifications for some of you, so it's not uniform unless all of you wear it. So get your uniforms modified so you can wear them, and then we'll kind of crack on that. Do whatever you want to do, as long as you don't wear shorts, because Emily